Hi, this is Erica Goyer with the National Perinatal Association and the Family Advocacy Network. Thank you so much for joining us today for this webinar. We're very thrilled to be talking with Dr. Janine Cross, and we bring these webinars to you 4 times a year or more, quarterly, to talk about topics that we think are very important and relevant for people who are both working in the NICU, working with high-risk perinatal populations, and especially for people who are leaders and advocates in the NICU community who are there to understand, support, and defend the needs of parents who have a NICU experience. So we are very excited because we thought one of the topics that really needs attention and care right now in our current healthcare climate is understanding the differences in care that we see that families and infants get both within NICUs and between NICUs. And we often talk about this in the context of NICU health disparities. And when we knew that we wanted to address this topic, I mean, we know many fantastic researchers and people who are out there addressing these issues and trying to describe to us what solutions look like. But we were especially excited when we knew that we could get Dr. Janine Cross to come and talk to us. So first, I want to tell you just a little bit about our webinars. Our webinars are brought to you by a collaboration between the Preemie Parent Alliance and the National Perinatal Association. The National Perinatal Association has a family advocacy network as one of our initiatives. And historically, the Family Advocacy Network has always represented the needs of NICU parents and their unique perspectives on what it is to have a high-risk pregnancy, a complicated birth, delivery, a NICU stay, or the loss of a wanted infant. We have partnered with some amazing friends and allies at the Preemie Parent Alliance. The Preemie Parent Alliance is an organization of allied NICU parents and leaders who represent the needs of their population from the family-centered perspective of care. They are fantastic as far as being a professional organization where these parent allies can meet, get professional development, and collaborate, but they also are a strong and dedicated voice to the needs of families in settings where we're talking about healthcare policy and advocacy. They also are amazing educators, and each organization and individual within the Preemie Parent Alliance provides direct support to families based on their personal experience and also the role as leaders in our community. So we're going to take a moment right now. We're so glad that you have joined us, and we want to know specifically a little bit about you. As we have our presentation today, we will often try to adapt what we talk about or come from the perspective of those who are attending our webinar live. So if you could take a moment, there's going to be a poll that my friend and colleague, Kira Sorrells from the Preemie Parent Alliance is going to launch right now. It should appear on your screen. And we'd like to know a little bit about you and the role that you play so that we can know how to address your needs and considerations during this webinar today. We're going to leave that up for a few seconds. Looking at the proportion of people who are voting right now, about half of you have. If you would continue to vote, we would appreciate it. A few more seconds. And I'm going to ask my colleague Kira to go ahead and join me and to let us know what she's seeing about our participants today.
Hi, Erica. Well, it looks like we have a large percentage, over 80%, are graduate NICU parents and are acting as support leaders in NICUs right now. And then we also have about 20% that are NICU nurses. Oh, make that 30%. I'm gonna I'm gonna go ahead and close the poll now.
Okay, thanks, Kira. Well, that's fantastic. That's really reassuring too. We often notice that during our webinars, we usually get a fairly equal representation between clinicians and providers and between parents and parent support leaders. So I'm extra thrilled that today we have even more parent leaders with us because, again, we know the effects that these sorts of health disparities we're going to be talking about have on the delivery of care and clinical care. But I think it's also so important that we start to acknowledge the impact of them in the broader context of what the family experience is in the NICU, both for whole populations, but also for the individuals that we support and serve. So thank you so much for joining us today. If you are a NICU support parent or leader, I'd like to tell you a little bit more about our presenter today. So Dr. Cross is an assistant professor of social work at Howard University in Washington, D.C. She is currently the president of the National Association of Perinatal Social Workers. And just a couple of years ago, I was very excited to see Dr. Cross's work that she was doing. She was working under as a help and leadership scholar under the National Association of Social Workers. She was a health policy professional. And during that time, it was fascinating to see the work that was getting done by people and by her and people like her, talking about the needs in front of the legislature of our families and representing us to our representatives in DC. She is also a current board member of the National Perinatal Association. Dr. Cross has a master's from Temple University in social work. She has an MBA from Rosemont College, and her doctorate of clinical social work degree is from the University of Pennsylvania. Right now, again, she is working as a professor and as a researcher at Howard University in DC, where she is still close to the advocacy efforts that she has become so integral to in the DC area. Dr. Cross, I'm so thrilled to have you here today. You have been an amazing and powerful advocate. You've done some fantastic research. Thank you so much for coming and joining us today. I'm going to go ahead and hand the screen over to you right now. Tell me if you have it.
Yes, you should be able to see my screen now. Can everyone see my screen?
Yes.
Thank you.
And you'll want to
Hi.
put it in the 100% mode if you can, where it takes up the whole screen.
Let's see. I think it is on mine.
Okay, great. I will go ahead and minimize mine then. Well, I'm going to put myself on mute, but again, welcome, Dr. Cross. Thanks for being with us today.
Thank you, Erica. I appreciate this opportunity to discuss health disparities in the NICU. I just want to start off by thanking Preemie Parent Alliance as well as the Family Advocacy Network for allowing me to facilitate this very important topic today. But I also would like to thank the participants who are taking some time out of their day to listen to this discussion and then hopefully participate and engage in this most important subject matter. I was thrilled to see that we have about 80% parents on this webinar today, because that's letting me know that not only do professionals understand that this is a problem, but also the families and parents of NICU infants who have to deal with oftentimes are the recipients of the services that we provide, are also understanding the importance of this, as these are sometimes the experiences that they have to undergo while they're in the NICU. Also want to say thank you to my nurse colleagues. I understand it's about 30% of them. Thank you for being involved in this, and hopefully parents, nurses, social work, as well as physicians moving forward, we can all work together and hopefully find some solutions to this issue and generate some ideas today. And hopefully this webinar will begin to give you all some ideas as well as some solutions on how to move forward on this topic. Again, this webinar will be covering understanding health and health disparities in the NICU. The objectives of this webinar is to understand healthcare disparities and its effects in the NICU. Hopefully, you'll also be learning what NICU providers and families can do to reduce healthcare disparities. Lastly, you'll hopefully be able to understand some of the programs and resources that are out there now to address disparities in your respective NICU. So, what is health disparities? This slide has a couple of definitions that are important when we're having this conversation about healthcare disparities. The two organizations that I use to identify some definition from is the National Library of Medicine and the Center for Disease Control. Healthcare disparities, according to the National Library of Medicine, healthcare disparities refer to differences in access to or availabilities of facilities and services. When we're talking about health status disparities, however, it is defined as the variation in rates of disease, occurrence, and disabilities between socioeconomic and/or geographically defined population groups. Another term that we're going to be talking about today is health inequity. And when we're talking about health inequity, we're looking at the differences, variations, and disparities in the health achievement of individuals, groups of people. In addition, a difference or disparity in health outcomes that is systemic, avoidable, and unjust. So again, we'll be talking primarily related to health disparities and health inequity. I want you all to have another definition though. It is from Healthy People 2020, which sets and monitors national health objectives every 10 years. Specifically, Healthy People 2020 have specific overarching goals to help our nation meet their healthcare goals as well as objectives. One of the overarching goals is to eliminate health disparities, achieve health equity, and attain health literacy to improve the health and well-being of all. This particular definition comes from the Healthy People 2020. Health disparities is a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. So now that you have some of the more formal definitions of health disparities, I'm hoping that you're starting to think about where you have seen in your profession or personal life where you may notice health disparities, whether it was with yourself or with particular groups of people, particularly related to health outcome. So you're probably now all thinking, why do they exist? So I'm going to start off talking to you a little bit about where we are about health disparities. But in order to have this conversation, we also have to think about how did this come about? When was our national awareness to these inequities in health outcomes related to groups? When did it first emerge? Well, actually, it was back in 1980. Margaret Heckler convened a task force to answer the question, why do disparities exist related to minority health? The Heckler report provides very, very, very comprehensive data on health disparities related to minorities. The Heckler report covers areas such as mortality rates, disease-specific mortality rates, suicide, homicide. It covers obesity, occupational factors, childbearing patterns. It includes low birth weight, infant neonatal mortality, as well as postnatal mortality. So earlier, even back in 1980, we were realizing that these disparities exist and it was a problem. The significance of the Heckler report actually elevated the minority health to a national level in terms of priorities. It also provided the impetus for transformative change in research, policies, programs, and legislation to improve health equities at all levels. And again, I thought that was important that you know that this is a conversation that we have today, but it's embedded in history and that this has been a problem for some time. And we are at a point today where it is a national priority. And so it's important that we start really critically thinking about this issue, as well as not only the populations that are affected by it, but also, again, really start thinking about how we are going to contribute to some of the solutions to this issue. Just quickly, I wanted to just make sure you're aware that the National Institute on Minority Health and Health Disparities have prioritized health disparities, particularly in terms of basic research on health disparities, but also getting a better understanding of what are the experiences for racial and ethnic minorities as it relates to health disparities, particularly with focus on medically underserved population. And as I stated before, the Heckler Report was very instrumental in initiating a sequence of events that occurred to help us address this issue more. So 1 year after the Heckler Report was released, the Office of Minority Health was established with a dedication to improving health of racial and ethnic minorities specifically. It also helped usher a bunch of programs and policies to help us answer the questions why. And so now we're making sure that we tend to get better answers for this, because we're not where we want to be in understanding why they exist. We have some answers, but again, a lot of research is now focusing on getting more concrete evidence-based factors for it, as well as evidence-based solutions to drive solutions to this problem. I also wanted to point out that the ACA, the Affordable Care Act, reauthorized the Office of Minority Health in 2018 and also expanded it to 6 other agencies. This, again, is to highlight that we are now at a point where we are definitely trying to highlight health disparities as a national priority, and making sure that all of the agencies, the Agency for Healthcare and Research and Quality, the CDC, the FDA, Health Resource Service Administration, CMS, and SAMHSA, all are starting to incorporate health disparities as a national priority, okay? Here are some of the answers to why. In terms of, this is what the Office of Minority Health, National Institute on Minority Health and Health Disparities, these are some of the things that they're doing to help us uncover better answers to why. Community-based participatory research is one of their goals. Enhancing capacity to conduct health disparities research, recruiting underrepresented racial groups, specifically in the scientific research workforce, developing health education programs for special population, and the inclusion of women, minorities, and other medically underserved groups in clinical trials. Again, important research to help us better understand why. What do we know? Before we get to that part of the webinar, I want to make sure that in our quest for understanding why they exist, today we are more aware that there's a growing gap in outcomes for minorities. They are having poor health outcomes related to the overall population, and there still remains a strong need for evidence-based research exploring factors related to health disparities, and again, developing the solutions for health equity. What do we know? We know that minority groups experience significant health disparities. When we're talking about minority groups, we're looking at African Americans, Native Americans, Asian Americans, Pacific Islanders, also has Hispanic and Latino groups. We also know that disparities exist based on biological as well as social determinants. What do we think about when we're talking about social determinants? Well, the World Health Organization defines social determinants as conditions in which people are born, grow, work, or live, age, and the wider set of forces and systems shaping the conditions of daily life. These forces and systems include economic policies and systems, development of agendas, social norms, social policies, and political systems. When we're thinking about health disparities related to minority groups specifically, we are looking at mortality, or the decrease in life expectancy. We're also looking at chronic disease, or increased rates of chronic disease, which we refer to as morbidity. We're also looking at homicide and suicide as well, higher incidence of those Minorities are oftentimes overrepresented in homicide and suicide statistics. We're also talking about prevalence of infant maternal mortality as well as low birth weight. When we're having this conversation of what we know, we're looking at, again, biological as well as social determinants. And I want you to start thinking about what do we mean and what we're referring to when we're talking about biological versus social determinants. When you're thinking about those biological determinants of healthcare, you're thinking about access to healthcare as well as access to preventative services. How minority groups have access or lack of access to healthcare as well as the preventative services. But we're also looking at those morbidity factors I just mentioned. How are they doing outcomes-wise related to chronic conditions, obesity, prematurity, and hypertension, as well as maternal morbidity?
Ross, would it be okay if I stopped you here and asked you a question?
Yes, please.
So this is Erica for National Perinatal Association. It's so fascinating to me, when we talk about the social determinants of health, those are things that I think end up sometimes being invisible to people, especially if that the presumption that everybody has, equal access to the care and services that are out there. And I was wondering about what can you tell us about, I often hear a focus on parents or NICU parents or mothers or families' behaviors. Like, this mother isn't coming to the NICU, we're not seeing her enough. Or this mother or this family was really late to care. And why is it that we didn't see them until they showed up in the emergency room? Instead of seeing it as individual behavior, can you tell us how, like, social determinants of health or the environment that you're getting care in, or the availability of local resources, how that might affect when a family gets care or under what circumstances?
Yes, thank you for asking that question. And it was actually right on time, Erica,
Oh,
because
good.
because the next slide talks more about social determinants of health. And yes, they are linked. The prior slide, I talked about access to care, and you eloquently identified more specifically how that access to care can look in the NICU. The second part of this presentation goes more specifically on how it looks in the NICU setting. But this slide here talks a little bit about what you're referring to, Erica, and that's the social determinants. How then is social issues that impact families, how does that play out in the NICU? Some of it is income. Sometimes patients cannot come and visit their infants as often as they would like because they do not have the resources to come, whether that's a vehicle, whether that's financial resources for public transportation. And when you think about the NICU course, the average NICU stay for an infant is 30 days. So when we're talking about one visit, yeah. When we're talking about multiple visits to the NICU over a course of 30 days, and again, that's the average stay. We all know that there are babies that may come in the NICU for about a week, but then there are also babies that stay in the NICU for up to for several weeks, up to a few months. And having to come up with the money, oftentimes the financial resources to be able to visit your baby daily. And that's notwithstanding if you have childcare needs for your other children. And if you need to spend significant amount of time in the NICU, that is, again, other resources, financial resources, if you don't have the family support that you need to watch your other children for you to come to the NICU. A lot of the NICUs now are more family friendly, and they do allow sibling visitation, but that's not across the board. So again, that's one example of how access can be an issue. From the system standpoint, hopefully a lot of our NICUs are now 24 hours, but I can tell you back when I started working in the NICU many years ago, that wasn't the case. We definitely had parenting visiting hours, which we expanded, and we don't have that anymore. But again, that would have also qualified for an access barrier. And when you're, again, adding the system barriers related to visitation hours, if they exist, Plus, you add the additional barriers of a family member or a patient who do not have the resources to come to visit every day, or the family support to provide care so that they can come in late hours to see their infant. All these things add up for a perfect storm in terms of social determinants of health, as well as the biological. Does that answer your question a little bit better, Erica?
Yeah, absolutely. Again, it's, I think people need to understand the difference between things that are outside of a family's control, which I guess I think of often as the social determinants, or, sometimes, like you said, that narrow range of biological things that might affect outcomes. But, that we need to maybe stop seeing it as a result of individual behavior if somebody receives lesser care.
Great. Thank you. And I also just would also like to add here, I just named some of the more transportation issues, but even as a system, sometimes depending on where your hospital is located, there are also parking resources too. I remember a lot of patients where I would work would need assistance with parking. Again, when you're talking about a one-time visit or a daily visit, with a parking rate anywhere between $15 and $25 a day, multiply that by several weeks or several months, it becomes very expensive. Even for middle class working people, that becomes a high standard to meet. But when we're talking about social determinants of health, we're also talking about, again, the income, low socioeconomic status, poverty, employment, race, culture, gender, sexual orientation. All these factors play into poorer outcomes. And I will go more in detail on how race, culture, and gender is one factor we do consider when we're looking at health disparities and outcome, but again, also resources. Health behaviors is also an area that we look at when we're looking at social determinant. And under these health behaviors, we're looking at sexual behaviors, perhaps substance use, exercise and nutrition. All these things play a critical role when we're having the discussion related to health disparities. I would like to draw your attention to a report by the Institute of Medicine called Unequal Treatment. It's called Unequal Treatment, Report of the Institute of Medicine on Racial and Ethnic Disparities in Healthcare. And this talks a little bit more about that issue of how race, culture, and gender and sexual orientation plays into health disparities. And the outcome of that report shows these key things. Racial and ethnic disparities exist, they impact care outcomes, and is unacceptable. We also know that unequal treatment related to related to ethnicity and race is embedded in historic as well as modern context. There's a history of discriminatory treatment toward minorities. We also know that social and economic inequality plays a huge role in health disparities, racial and ethnic discrimination. And we also know that systems and providers contribute to discrimination across the board. This report was highly controversial, and as you can imagine, got a lot of pushback. But I think one of the key pieces of this report is it really highlighted to healthcare providers that there are systemic issues in our hospitals and healthcare settings to where our providers' attitude and policies, systems we set up do not set a tone for better outcomes. And if we take a critical look on our practices, our attitudes, how we deliver care, we may question whether we're adding to the health disparity piece when we're talking about how we set up our systems, how we address the needs of the patients that come in. Again, this report I feel is very crucial. If you have time to look it up, please do. But again, it really brought race, ethnicity to that conversation of health disparities, as well as discriminatory practice and oppression. And hopefully the goal for this report was to get providers thinking in terms of, we all have a say in terms of health disparities. We can all impact it, but we have to look at some of the practices that we are engaging in as providers, as well as the policies and our interactions with minority groups.
So, Dr. Cross,
Yes.
could you maybe give an example or two? Because I think you're absolutely right. I think oftentimes people think that they are not participating in a system that promotes these sort of things. But can you think of an instance or a policy or a behavior that you see clinicians or institutions like hospitals do that contributes to this sort of health impact on families?
Thank you, Erica. Yes, I can actually. I can tell you, I'll actually piggyback on the example that I provided earlier, or actually you brought it up when you had talked about um, families coming to visit and sometimes concerns or attitudes of providers related to families coming to visit their infant in the NICU, or they're not coming enough to visit or engage. A lot of times, we don't oftentimes look at some of the policies that we put in place that don't facilitate good visitation by parents. One is sibling visitation. There are some NICUs who restrict or deny sibling visitation out of concern for infection control. Now, it makes perfect sense why, a lot of NICUs would not want younger children, toddlers, perhaps coming into the NICU out of concern that they may be sick, they may have colds, and this can put a NICU infant in a lot of trouble in terms of infections. However, sometimes we make those calls not realizing that we've just added to the access barrier for parents. So if they're not allowed to bring their children to the NICU in order to visit, they do not have the resources or the funds for childcare, they do not have strong family support to help watch the child, then that parent needs to stay at home with the children because childcare is not available to them. And then by that same situation, then the providers tend to get attitudes or get very angry or judgmental related to that parent's visitation, without not looking at the part that they may have played or the system may have played in decreasing that access to that infant. Does that help provide an example?
Absolutely. And I was thinking about it as you started to describe that. I was thinking about my own experience. One of the NICUs that I spent a lot of time with and worked in and supported parents in, every time I would walk into that NICU, I'd walk down a long hall and there's this little alcove there that just was kind of where a doorway was. And there would almost always be two or three kids sitting there, sometimes on their own, or sometimes with somebody who looked like a family member or grandparent or an aunt and uncle. And they would be hanging out there literally on the floor of the hallway because they weren't allowed to go past those doors into even the waiting area because of hospital policy. And so every day as I walked to the NICU, I was reminded that those family members couldn't be there, and the parents who were in the NICU were making this really hard choice of going and seeing their infant versus leaving the rest of their kids and the rest of the family to figure out on their own what to do because they couldn't be a part of the NICU visitation.
Mm-hmm. Mm-hmm. It's a real issue, and I think we will not be able to do anything but scratch the surface of this issue if we don't, one, recognize that it's a real problem, so much so that, as I stated earlier in the webinar, it's at a point now where we are taking health disparities and we're making it a national priority. But also, we have real statistics to say there's a problem here. I'm going to take just a few minutes before I open it up to ask panelists what their experience, personally or professionally, may have been with health disparities. But I want to first go over some statistics here. Related to healthcare access and preventative health services, the CDC's Health Disparities and Inequalities Report 2013 identifies some very hardcore statistics related to health disparities. And regarding to health care access and preventative health services, during 2010, approximately 2 of 5 Hispanic adults and 1 of 4 non-Hispanic Black adults were classified as uninsured. In 2010, the uninsured rate for adults ages 18 to 34 years was approximately double the uninsured rate for adults ages 45 to 64 years. Insurance is, again, one access point it's one area that we also need to look at when we're talking about healthcare and access. Erica identified a little bit behavioral factors. For instance, binge drinking is more common among persons ages 18 to 34 years of age. But we also know that adolescent birth rates, for instance, despite an 18% decrease in adolescent birth rates during 2007 and 2010, rates for non-Hispanic Black and Hispanic teenagers remain approximately double those for non-Hispanic whites and Asian Pacific Islanders. We also know that smoking is an issue globally, but also in our perinatal population. Although some progress has been made in reducing cigarette smoking among racial ethnic groups in recent years, little progress has been made in reducing cigarette smoking among persons of low socioeconomic status. These are behaviors that result in having poor outcomes for minority populations. But we also have information on mortality. The infant mortality rate for non-Hispanic Black women was more than double that for non-Hispanic white women in both 2005 and 2008. We also know the suicide rates were higher for non-Hispanic whites and American Indian, Alaska Natives compared with non-Hispanic Blacks, Asian Pacific Islanders, and person of Hispanic ethnicity. Again, these are broad areas that I'm talking about, but there are health disparity areas. And when we have this next section where we talk more specifically about how these broader disparities impact our families in the NICU, we'll go more into detail about that. So up until now, we talked a lot about understanding what health disparities are, how they affect minority groups. We've also talked about how it's been raised to a national priority. The second part of this presentation is going to go more in depth about how it looks in the NICU and how those areas of disparities impact our families every day. But before we move there, I would like to ask the audience, what have their experience been with health disparities, either personally or professionally?
So, Dr. Cross, I'm seeing one question here, and it goes back to what you started to mention too about even though the rates of teen births, people giving birth to babies during their teen years, has lowered, that the numbers are, still fairly significant overall. And this person talks about their own experience having been 19 when they gave birth, and about how they felt that they were perceived by the staff when they came in. But that also made me think about my own experience, which was I was also a teenager when I had my first child. I was 19 years old when my first baby was born. And then I was 20 when my second one was born. And that's not ideal. But anyways, ended up one night, I can remember specifically for myself, taking my baby into the emergency room. It was at a time when we weren't covered by health insurance, and they were having a hard time breathing, and I was very, very concerned, and of course, being uninsured, was very reluctant to go and even go to the emergency room where I knew there was going to be expensive care. But they turned me away and my infant away, saying I was worrying too much. It was just a cold, not to worry. And now I look back on that experience, and knowing what I know now, I really suspect that my child had RSV. And that makes me cringe that was just one instance where I think how people perceived me and my social determinants of health affected the care that my baby got.
I actually have seen it too, and earlier in the slides I had talked about that important report from the Institute of Medicine, and really identifying how is it that we as providers deliver care, and how we may not deliver it in an equitable way, right? And I think that's some of what your experience has highlighted. And I'm hoping, I'm hoping that as I'm talking about this, that a lot of the providers or the parents that are on this, participants that are on this webinar are really thinking about times in their course, whether it was in the NICU or personally, where they may have come across providers or systems who may have perpetuated disparity outcomes related to the interaction, or not using the opportunity with that interaction to improve overall health outcomes, right? And it's a system and providers issue related to sometimes discriminatory practice, whether they're overt or covert, conscious or unconscious. Sometimes it's now taking your attitudes and beliefs that may not quite be accurate and then conveying them onto a minority group rather than solicit from them their experiences. As I stated earlier, a lot of the national priorities now are really looking at research in terms of understanding the experience of minorities related to health disparities. And so sometimes us as providers in the system, we need to do a better job at understanding what it means for that particular patient in terms of accessing care, perhaps understanding the system itself, understanding what's necessary, making sure that we make sure information is clear, understandable. We take into account resources of that family, their ability to visit, their income. We take into consideration racial, spiritual factors that may impact care in terms of cultural belief systems, spiritual belief system. All of these things impact. But instead of trying to understand it from the point of view of the patient, oftentimes what we do is we convey what our belief systems are and what we think normal behavior, visitation, parenting should be. Again, with teenage parents, I feel as though we should always, with all patients, hold everyone to the same standard of care in terms of, yes, she is a teenage parent, but that's a chronological age. What we need to do is see if she's bonding with her child. And that's not a teenage issue. That's a mothering, that's a parenting goal for NICU providers and hopefully for parents as well. We need to see their abilities to perform cares on their infant. Give a temperature, give a bottle, read the infant cues. That's not a chronological issue. That's a training issue perhaps, or that may just be making sure that parent has enough opportunities to learn the cares for the baby. Could it be it's a challenge for the teenage parent, or could it be that we never allowed her with enough opportunities because the baby was in an isolette for several weeks, perhaps with a breathing tube for several weeks, perhaps on not able to feed all the time. There's plenty of reasons why, but I think sometimes as people we default to what is this person presenting to this as a teenage parent, so that's the challenge. No, it could be a little bit more complicated than that. So again,
I think you're absolutely right. And I just think back about, and of course I've now been very sensitive to seeing that with other people, but I think about that one incident that made me feel a little bit ashamed maybe, or question myself, or, you know, where I didn't get positive feedback about seeking care for my baby. And I can't even imagine dealing with that over and over and over again. So I really appreciate you bringing that up.
Thank you, Erica. And so now we're going to get more in depth with our discussion of healthcare disparities, and specifically as it relates to the NICU. I want to draw your attention to the Urban Disadvantaged State of the World's Mother 2015 report. The findings of that report basically lets us know that disparities are worsening globally. The poorest children in cities have the highest risk for fatality. This report also identifies the poorest urban mothers as being deprived of life-saving health care. We know that child death rates are grounded in poverty, deprivation, and discrimination. Specifically, DC, where I'm currently reside, the DC metro area has the highest infant death risk, and great disparities. This report also identifies that solutions exists based on progressing countries. So even though the state of affairs globally related to maternal child health is concerning, we have the solutions, we have examples out there to help improve outcomes. But then you're probably asking why? Why then are the disparities so great when we have some solutions, we have some examples of countries out there doing well? And again, I just want to make sure I identify that this report specifically looks at maternal and child health outcomes globally, but specifies specific areas in the United States that are struggling. I know for a fact, just recently, the DC Council approved the Maternal Mortality Review Committee Establishment Act of 2017 because the maternal death rate in the DC area was 40.7 per 100,000 when the national average was 19.9 maternal deaths for 100,000. So this is a specific issue. So I want to just make sure everyone knows that even though we're having this conversation, it's important that we understand this issue as being globally, but we're struggling with this in maternal child health right here in the United States. What are some of the factors when we're thinking about the mother? What are the effects of health disparities on mother? We're looking at maternal mortality rate, the example I just provided to you here in DC. We're looking at obesity. Again, this is one of the chronic conditions that we know is an area of focus for health disparities. Premature birth, mental health issues, preconception, prenatal, postpartum care access. These are the biological determinants, okay? So when you're looking at our mothers that come into the NICU, we're looking at these areas that we know are major areas for health disparities. When we're looking at the social determinants, we're looking at race, ethnicity, and culture, understanding our practices, taking our time to understand the experiences of individuals and families that come into the NICU, understanding from a racial or cultural standpoint, what does it mean to have a baby in the newborn intensive care? What does it mean to be a parent of a child in the intensive care? How does the family perceive that? How does the mother perceive that? Not just the admission, but the entire course, procedures, tests, assessments, discharge, breastfeeding, medication. All these things have to be looked at, and it's a complicated conversation, but we have to understand that we know that minority groups have poor outcomes, and so what are we doing when we have our opportunities to meet with these families? How are we assessing the mother and the family and taking into account race, ethnicity, culture? How are we taking into account sexual identity and orientation? How are we perceiving the health behaviors if it's a teenage parent, if it's a parent who's not visiting often? How are we perceiving the environments that they come into the in interaction with? When I'm talking about environments, I'm speaking about their home environment, their community environment. I'm talking about the environment of the hospital and the environment of the NICU. How is that interaction going for that mother, given sexual identity and orientation, given race, ethnicity, and culture? These are things we need to be considering when mothers and families are coming into our NICU. Again, the resources, what are their financial resources available? What are the family resources available? Is this parent or family insured? Are they uninsured? What does that mean for that parent? What kind of burden does that place on the parent? Social support as well. Again, who are the supports there, and how do we account for that as a NICU? So when we're talking about healthcare disparities with the mother and family, again, we're still looking at it from those biological determinants as well as the social determinants. Similarly, with the infant, biological determinants in terms of health outcomes, we're looking at infant mortality rates. We're looking at prematurity. We're looking at low birth weight, small for gestational age, those chronic conditions again. Developmental, when we're thinking developmental with preemies, we're talking about neurocognitive development, right? As well as their physical development and how this may impact their behavioral outcomes and overall outcomes when they're discharged from the NICU, as well as their health outcomes. What are the biological determinants? This is the things that we want to be critically looking at in the NICU. Again, similar, we're looking at also the social determinants. What are those things that we can impact to really give that infant a better chance of better health outcomes? Again, we're back to race, ethnicity, and culture. Bonding and attachment. What are we doing as providers to facilitate bonding and attachment? Understanding maybe how maybe that family cannot be there often and regular for that family. Is there things that we can do policy-wise to enhance family involvement and care? Can we remove some of the access barriers for that family so that they can bond with that infant more? If that mom, encourage mom to breastfeed. If we can perhaps address some of the barriers that may prevent her from wanting to breastfeed. Same thing with the environment and resources, but the environment is a little different when we're talking about in the infant. We're still looking at the environment of the NICU as we would the environment of the NICU for the mother, but we're looking about how can we make that environment best and ideal to give this infant the best outcomes when going home. But we're also looking at that infant's family environment. How best do we support that family environment? Again, a way we can target health disparities by addressing that family environment, improving that support, making sure we discharge in a way where that family is educated and comfortable to take that baby home. So now we can also account for the home environment to a certain extent, and that we know that the providers are competent. And when possible, have a better idea what that home environment is looking like before we send that baby home as well, so that we can give that baby the best chance in terms of outcomes. And again, social support. So again, on the left side there, you're looking at some of the biological determinants for health disparities related to infants, but you're also looking at those social determinants as well. And what I know a lot of the providers here are really interested in I can also sit here and have this longer conversation about the biological determinants and the social determinants from the NICU specific standpoint. Here we're looking at preconception, prenatal, and postpartum education. What are we doing as a NICU? Even though we're catching them at one point of the hospital course, we can reach out before and work with services such as OBGYN to talk about what can we do to help better educate patients related to disparities related to NICU. What are some of the things that will increase your chance of factors for low birth weight, prematurity? Educating them that. Maybe educating families related to health behaviors that may increase their risk of having an infant in a newborn intensive care unit, or using that as opportunities to do better education to highlight certain minority groups as being high risk, given what we know about health disparities, and what are some of the things that they can do to decrease some of those disparities. Again, health lifestyles as well as wellness, prevention, and education. I think that's really key. But I think in the NICU, what we do is we tend to focus on the NICU course alone, but not realize that there's a continuum of care that needs to be considered when we're talking about health disparities. Again, how can we teach this mother or this family how to live healthier lifestyles, whether it's smoking in the home that could compromise the infant, especially an infant that's been on respiratory support for periods of time. What are some of the things that we can start educating mothers now about how to have a more wellness focus to address her chronic issues, so that may decrease her chances future for dealing with an infant in the newborn intensive care. Again, this also, I'm talking about a paradigm shift when we're talking about prevention and wellness versus an intensivist and a chronic illness approach. I think oftentimes when we're in the NICU, we're really on an intensivist chronic lens in terms of how we deliver care, but we have to understand when we're talking about health disparities specifically, we are also talking about those chronic diseases and chronic illnesses, or those chronic factors that lead to health disparities long term or poor outcomes long term. So we just can't take an intensivist approach. We also have to be doing education on prevention and wellness as well as a NICU. And I think that's something that's an area that we don't explore enough, and it's an area that we can really impact health disparities. I know that when we do rounding in the NICU, oftentimes we're doing provider education. We're sharing research, we're sharing standards of care, best practice. How can we use the resources, knowledge, and education that we have in the rounding sessions to get an infant home quickly, safely, or more safely. But what we don't do is use that information and research oftentimes to educate families on what they need to know to live healthier lifestyles, to perhaps help them leverage that information to have better outcomes. So understanding the unique experiences of families as well as the strengths of patients is important, because doing that, again, enhances our professional relationship with that particular family. And so that when we're talking about doing that preconception, prenatal, and postpartum education, we're doing it in a way where we're maximizing the strengths of that family, but we're also understanding their experiences so that we can customize care for that particular family. Addressing barriers to care or quality of care. Again, I think sometimes we don't think that this is our role. I'm a social worker, I'm a trained social worker. I was a social worker in the NICU for 15 years. I can tell you that everyone in my treatment team were very, very, very sensitive about removing barriers to care and improving quality of care, from a biological standpoint and a social standpoint. I knew there were nurses that were willing to refer patients to hospital services. They were very quick to enlist my role to help help patients remove barriers to care and improve overall care. Creating supportive, resource-saturated NICU environments. So again, it's making sure that we understand what the health disparities are in general, understand what those disparities mean for particular families, and then creating that environment in the NICU where we support families understanding those factors that can really compromise outcomes for them. And then improving opportunities for bonding and involvement of that family whenever we can. Again, we look at it oftentimes from a clinical lens where we're really trying to do what's best for the baby in terms of clinical care, in terms of procedures, but sometimes at the expense of how then can we improve this family's involvement with this infant? How can we better prepare this family to care for this infant to improve outcomes overall? So now we're at what can be done. Here are my recommendations. And as you probably remember earlier in the course, I talked about how health disparities have been elevated to a national priority level. My question is, have we done that in the NICU? Now that we know that on a national level, health disparities is a priority, we need to now make it a priority on the clinical level when we're talking about in the NICU. Intensive support services should be a priority. Understanding how we support patients with their chronic illnesses. How do we support them with their infant in the NICU? How do we support them understanding that oftentimes the systems that they are interacting with every day are discriminatory and oppressive? And then how do we strengthen the health systems themselves to address this issue of health disparity, which is very difficult, challenging, and complicated? How then do we collaborate between services? How do we have OBGYN interact with the NICU in a way where we're constantly understanding the disparities that exist with the populations that we serve? And how are we leveraging resources across the care continuum to support them, again, preconception, prenatally, if the baby is in the NICU and when the baby's going home. This is also engaging primary care pediatricians to make sure we're all working together to address these health outcomes. How do we lower healthcare costs? What are the things that we need to do in terms of making sure patients have insurance, they're covered, and they're not underinsured? How do we increase health awareness through health awareness programs? How do we help accessibility for the poorest urban residents? Again, these are all things that we can do better, and I think these are areas for improvement across the board. But you should feel a little bit comfortable only in that the things that I'm talking about now, I believe it's something that many providers are doing, but we can do it better, and we can do it across the NICU services and across hospital services as well. So again, we're looking at better care for mothers and babies before, during, and after childbirth. How do we possibly increase the use of contraception to prevent outcomes that are unwanted? Effective strategies to provide free or subsidized quality health services for those people who are most in need. And from the NICU provider standpoint, how do we enhance social services, particularly those services that we know impact patients, the most vulnerable, and how we enhance social services in a way where we make sure we address education issues in terms of people who have lower education, people who have lower finance and resource, people who may be unemployed. Um, Again, as I mentioned before, strengthening interdisciplinary collaborations, that's that having a strong collaboratory relationship, nurses with social workers, nurses with physicians, social workers with physicians, but also making sure that we also have good collaborations with other departments in the hospital. This is pastoral care, to make sure we're giving the appropriate amount of spiritual support. This is patient accounting, to make sure we're getting patients insured, or at least their hospital stay is covered, so we don't add to their financial burden. And how do we support efforts to improve healthcare reform? As I stated earlier, ACA has been pivotal in really highlighting health disparities as a national priority, and really focusing a lot of research in this area so that we have better understanding on why they exist and how do we counteract that. But also, I think also ACA has also did a lot of expanding coverage for many. And we know, again, access is a huge area of focus for health disparities. In terms of additional things that NICU providers can do, is make minority health outcomes a NICU priority. Having a stronger commitment to creating and fostering relationships, specifically in minority communities. You can do this through health fairs, engaging in community-based institutions like churches and schools to do more education about health disparities, low birth weight, maternal mortality, infant mortality. We can do a better job getting out of the NICU itself and doing more education in the communities related to health disparities. CMEs versus SMEs related to social issues. We do a very good job making sure physicians get continuing medical education, but how well do we do on making sure they have continuing social education, understanding how disparities exist, understanding how discriminatory, oppressive practices, delivery systems impact overall care and outcomes from that patient. Again, we do a good job of making sure physicians, nurses, providers are trained medically, but how well are they trained with making impacts in those social determinants of health? And also integration of NICU health equity policies. I think we need to do a better job at looking at how our existing policies may impact health disparities, but we also need to create policies when we feel as though health disparities exist in our respective NICU, and there's something that we want to do about it. And also making sure that the workforce is racially, ethnically, and culturally diverse. This is something that is taking on a national focus as well, and I believe NICU should do the same. Making sure that we employ people who have different cultural experiences to enhance the overall service delivery system for NICUs. Prioritizing patient and community education, as I mentioned before, is going to be key to this. But we can't do this unless we have better relationship with the communities in which these NICUs are situated, and do a better job of really improving the relationships that NICU providers have with minority populations. And lastly, having health equity program development. But I really think this can't be done within one discipline, within one provider. We really need to enlist them all. OBGYN, pediatrics, perinatal evaluation center, maternity, labor and delivery, NICU. All these service providers need to be involved, and we also need to make sure all the key players are involved well, like social workers, psychologists, community health workers, physicians, respiratory therapists. Every particular provider that comes in contact with families in that NICU, we need to all collaborate together and determine how we can make sure the outcomes for our NICU patients are more equitable across the board for all. And last but not least, I've added here some resources that hopefully will help you on this journey. The first one is Tools from CAPT, Increasing Cultural Competence to Reduce Behavioral Health Disparities. The next one is the National Partnership for Action to End Health Disparities Toolkit for Community Action. Health Research and Education Trust Disparities Toolkit. A Practical Guide to Implementing National Class Standards. Tools to Address Disparities is also listed there on the right side. Equity of Care, a toolkit for eliminating healthcare disparities. And there's also one listed there for the American Medical Association. That one you would have to purchase. You can Google that. It's not necessarily a free resource, but it's one out there available for physicians and medical providers who are interested in it. And the last one there is Advancing Effective Community Cultural Competence and Practice in Family-Centered Care. And that's a Joint Commission resource, again, to help health providers or health settings who are interested in really addressing the issue of health disparities within their NICU. And again, I hope if you take nothing else away from this webinar, to really think about your practice in the NICU, really think about health disparities globally, meaning understanding what they are and how they impact everyone, but then also drill it down to understand what it looks like in the NICU. And I hope that you really understand that this is an area of strong focus now nationally. But now it's up to us NICU providers and professionals to make it a clinical priority in the settings that we work in every day, so that we can improve outcomes, maternal child health outcomes across the board. Questions?
Thank you so much, Dr. Cross. And I've been keeping an eye on some of the questions coming in and messages coming into us, and also I've been kind of thinking about again, how this all kind of strikes me and what my observations are. Do you have a minute to kind of hear some observations and answer a question?
Please.
Sure, cool. Well, one of the things I noticed that I thought was really great is I love the term you used about having a NICU that's resource saturated. And I thought that was really fantastic because, again, it's one of the things is, one size doesn't fit all. We all know that. And the resources and everything that we provide and the diversity of resources is so important. And that got me thinking about how, whenever I'm looking for a resource for myself to educate myself or a resource to help families, that's one of the big strengths of like peer-to-peer and parent-to-parent support is you can almost always find things that are created like by us and for us. And what an amazing amount of resources that there are out there, whether we're talking about like midwives or some of the First Nations tribal health groups that look at maternal health through that lens, or whether we're talking about using midwives and doulas who are part of somebody's community who are able to give them specific resources that address their needs. But like I also know I've seen you and I have talked about many different cases of advocating for families or for people who are vulnerable or underrepresented. You and I have talked a lot about how to advocate for families where, maybe mom is a substance user or something like that. But what are, what's the philosophy that you approach advocating for families? In other words, what do you have to share with us, especially as parent leaders, that we can do to either advocate on behalf of people or to empower them to advocate for themselves?
Good question. I will tell you one medium that we used oftentimes in NICU settings, and for me as a social worker, it was one way is family meetings. And these family meetings were to improve the communication between providers and family related around a specific issue. And one of the things I would always tell families is that the family meetings are oftentimes initiated by the medical team and to give you updates and to make sure you understand what's going on with your baby. But it's also an opportunity for us to build a professional relationship and improve communications. But I would also tell the families you can elicit a family meeting just as well as the providers, to let them know this is an equitable service here. If you feel it's time to call a family meeting because you need to better understand a procedure or better understanding a course of action, you are empowered to do that. And I think having those conversations early with family members, letting them know that they are part of the medical team in terms of the NICU. We are not just telling them what we think their baby needs and that's what we're going to do. But we do want to have a conversation, but it also improves that relationship, and that the family can also let them know what their unique experiences are so that we can incorporate the family strengths as well as the family challenges in the plan of care. And I think that's what you were talking about earlier when you were talking about the strength of the peer support programs. One of the reasons why I believe they're so supportive and they're so effective in our families is because there's a shared unique experience that those peer parents can provide. And it's really coming to that family or that mother and saying, I understand this experience. I was in your place. And now let me help you, support you, and let me help you navigate the system. Because part of it is me supporting you, but I'm supporting you so that you feel empowered and you feel that you have the resources to navigate the system on your own.
I really love that. I think that's important. And, thank you so much again for coming and talking us today. It leads to, I mean, every time we have one of these presentations, I often end up with, new additional questions. So I hope it's a conversation that we can continue to have with each other and to share with our audience.
Thank you so much for having me, Erica. And again, I just want to thank Preemie Parent Alliance and Family Advocacy Network and all the many parents and nurses that are on. If anyone wants to reach out to me or have specific questions, please feel free to do that. Please make sure you follow up, and I'm sure my information will be listed somewhere for contact.
Thank you so much for coming and being with us today. And Dr. Cross, again, it's always fascinating to talk about these things, and they're so interesting and so engaging. And we would just also want to thank everybody who came and participated with us today, and for all the things that you do in your various roles to support families. We want to let you know that this recording is going to be available later this week. We're going to have that posted for you online so that you can access it and come back to it. We encourage you, please go and visit these different organizations. The National Perinatal Association, we have a special interest in these topics. Preemie Parent Alliance, they're providing direct services. But again, the organization that Dr. Cross is the president of right now, the National Association for Perinatal Social Workers, they are such an amazing group. I'll tell you, they have a conference coming up in 2019 in May. There is a call out for papers right now. So whether you're a social worker or whether you play a role with families within the perinatal community that has effects on these social determinants of health or on the care that ultimately families receive, This is an organization that we really encourage you to learn more about and to attend their conferences and consider to, contributing to the conversations that go on at these conferences, like the one that's going to be next year in Savannah, Georgia. I've attended the conferences. They are fantastic. I've learned so much. I've made connections with people that I've continued to go back and have conversations with and learn from. Again, I am not a social worker. I'm a parent support person and an advocate, and yet I have become a member of this organization because of what it is that they have to offer. If you are a social worker, please take a moment to look at their Innovation Programs and Research Grant. This is a fantastic opportunity to, if you have an idea that you want to get implemented or you have some information that you think if you gathered could improve perinatal care, this is a way to get funding for those initiatives that you might not be able to find from other sources. Again, the work we do is so important, and yet sometimes it's hard to find the resources to do it, and the National Association of Perinatal Social Workers provides that. I also want to tell you that if you are a parent advocate or somebody who's interested in parent and family advocacy for the preemie and NICU community, that there is not a better organization that you could join of like-minded peers than the Preemie Parent Alliance. They have their summit coming up later this month in the DC area at Falls Church, Virginia. Again, I've attended these and they have always been a great way to improve the resources, people, and tools that you have available to you to make positive changes in neonatal care. The National Perinatal Association is very committed to recognizing, describing, and addressing the sort of barriers to care that keep families and mothers and babies and fathers and siblings from getting the care that they need. We believe strongly that every patient has a right to have their healthcare goals recognized and honored, that every baby deserves the best possible care that we can offer, and that all of us deserve to receive care and services and support in the communities that we live in. National Perinatal Association, our conference next year is in April in Providence, Rhode Island in New England, and we're going to be focusing on programs and solutions and strategies for addressing healthcare disparities and inequities. I'm absolutely certain that we'll have Dr. Cross there again talking to us and sharing things with us. But again, thank you so much for being here with us today. We hope you have found this valuable. We hope it's a resource that you will continue to return to, because both the Preemie Parent Alliance and the Family Advocacy Initiative of the National Perinatal Association is committed to paying attention to the issues that make a difference for families, to discussing them within our communities, and to finding and enacting solutions that improve the care and the support that every family gets. Thank you so much for being with us. Please offer your feedback. We'll continue to share with you over the next couple of days, not only this recording, but links to the resources that you have seen, ways to follow up with Dr. Cross, and ways to follow up with getting more involved with our organizations to help improve family-centered care. Thank you so much for being with us. Have a fantastic week. Good luck.